Good morning, everybody. It is a pleasure to be here with Dr. Carlos Medranda, and my name is Ammar Alotiabi. So we have a female in her 50s, referred from a peripheral hospital. She had a cholecystectomy 15 years ago, and came to their hospital with ascending cholangitis. They attempted conventional ERCP and tried to stent her, but they failed due to the large stone impacted in the left hepatic duct. So they end up putting a percutaneous drain, and she was transferred for...
They mentioned PTC failed, possibly failed cannulation.
So here Dr. Carlos is already inserted the cholangioscope into the bile duct, and we'll be seeing the stone soon.
What is your strategy in this case, Ammar?
Can you tell us about your strategies now, like with the cholangioscopy, what you are going to do?
So, Dr.
Yes.
Carlos,
So now we have very big stone, impacted stone, and what we are looking now is that this is a dark stone. It means it's not because of cholesterol. This is more because of calcium stone. So this stone, this needs to be understand that this probably is a very how to say a strong stone, right? So it means we will need to make a very good job here.
Can you show us the fluoro picture? Where is the cholangioscope? Where is the position of this duct of stone? Can you show us the fluoro? Where is the picture? Where is the stone?
So the fluoro, yes.
can we show the first fluoro image? Not this one, the one before.
So Carlos, what's your preference here, EHL or laser?
Well, I have EHL in my unit.
Yes.
I prefer to use, for these cases,
Show the picture.
the walls. It's a German company that we can use the 2.0 working channel. So it's strong EHL, so you can destroy this kind of stones quickly. But we can use any kind of EHL. One of the disadvantages that I see with this kind of the EHL is that you have until 1,200 shots. But now I will try to go with my EHL treatment. Just I need to try to go in the middle. So I will try to make a tunnel in the middle of the stone. So in that way I don't need to lose my time, going around and going directly with this. The second tip, I believe all of us understand very well, is that you don't need to be approached. You need to have certain distance, and you need to use saline solution when you are working with this. Okay, I think it's you can have with both kind of energies complications if you don't do well. It means you need to avoid to apply over the biliary tract, over the epithelium of the biliary tract, or the layers of the biliary tract. But even if you have any kind of complication, we can solve it. We have a stent. If you have a leak, we have a stents. If you have a bleeding, you can put a metallic stent fully covered. So this is not a limitation, to my opinion, right?
Yeah, Doctor, there is any risk for gas generation or expulsion?
Well, it's always a risk if you are not using, saline. I believe there is a kind of risk, but I didn't have this kind of risk until now. So in my experience, we perform almost 300 cholangioscopy in my units a year. And I believe embolization or something like that we can have a risk when you are not using the correct,
Carlos, what about the technique? Like, where do you target in a big stone? There is a risk of tunneling. Can you explain that? How do you approach a big stone?
Well, I go inside, you know, try to go in the middle of the stone. As you can see, I already, you know, almost destroyed the whole stone. I am just trying to clarify here if I am fine or not. But I am trying to always to make a tunnel in the middle because that will be easier to perform the fraction of the stone. And this is why I try to go in the middle and not go by
thank you, Carlos Ammar. Thank you very much. Great case, great demonstration. So we'll move to the other room and we'll try to back to your room.
For a stone, if you middle, you would, you know, do in 5 minutes. So we were waiting for you. So you can see the whole stone is clear, it's completely destroyed. And we use the fluoroscopy. So I wanted
Can we
to
have
show
the
in big the image of fluoroscopy.
please?
That looks very nice now, all small fragments.
So you
It
see,
looks very nice.
so the biggest stone is not more there. So my next strategy now is I will remove everything and I will use balloon dilation just to make a dilation from the papilla, right? And before to perform a balloon extraction of the stones, you know, destroy the stone. We were using the EyeMax, is a new cholangioscope from Microtech. We were using it for making our cholangioscopy and
Carlos, will you put a
EHL
stent
treatment.
after this? Will you put a stent into the CBD after clearing it?
Well, it will depend. I believe it's not necessary.
So, Carlo, what do you think the size of
So
the
let's
lift
see better.
after crushing
And
it? What do you
I will
think
pass now
the size
a
of the
balloon
stone
dilation.
was?
So Carlos, there's a question from the floor. What do you think, how big the stone was?
How big? Well, I believe 3 centimeters, more or less.
Thank you.
I believe that the stone was easier to destroy because of the stent that that this patient had before, you know, the PTC. It helped a lot.
If I heard
That's why the
correctly-
destruction was easier.
Carlos, if I heard correctly, you've
So-
been using EyeMax, is that right?
Yes, I was using the EyeMax, yes.
So how is the experience
11 French EyeMax.
compared to the spyglass and their version of EHL?
Yeah, until 10 first. Well, there is a few difference. IMAX, well, you have available in the market 2 different sizes. One is 11 French and the other one is 9 French. The 11 French have 2.0 working channel, so you can use biggest EHL. You know, in some kind of cases, I use biggest EHL catheter, so for destroy. And then you have, we can go until 12. We are until 12? Okay.
Can we see
10,
the
okay.
endoscopy view, please?
Endoscopy view, please.
So there's another cholangioscope relatively recently come into the market, line set. So they also have 2 scopes. So thinner one, 2.6, and the bigger one. Any experience with that?
Well, the bigger one, the 11 French, you can use, you know, different size of other kind of EHL catheter, right? So I think there's some kind of advantage with that. Nowadays, I have a prototype that is a 7 French cholangioscope. In the future, we'll have a 7 French cholangioscope with 1.2 millimeter working channel. That is the standard one from Boston Scientific or other cholangioscope. And this will make us a big advantage to deal with not just with the diagnosis, of also with therapeutic, you know, treatments. one of the big advantage now of the 11th range is that with the working channel we can pass metallic stent through the cholangioscope. So in certain cases where it's very difficult to reach the stenotic area, so we can have a direct treatment on the direct visualization using just the cholangioscope. So in the future we will see more and more direct access with the cholangioscope when deal directly, not just using fluoroscopy, just using video imaging. So probably it's part of the future. So now we are deflating now. Okay, perfect. And I will remove. So this will be easier to make.
And Carlos, what was the size of the balloon?
Stones, I always like it to. Oh, it was 10, 11, 12. So we delayed it until 12 because I don't need to delay more.
And
I will pass the guy wire.
And how long you keep it inflated, like?
At least 2 minutes.
And Carlos, won't you do it before doing the cholangioscopy so you can have easy freehand access, the sphincteroplasty? The balloon dilatation before doing the cholangioscopy.
So Carlos,
no, not before, because of okay. Remove the right wire a little bit. Not before because I need. Well, I don't believe we are there. We are in the cystic duct. Okay, remove please. So just one moment. Okay, I will try to make a. Let me see. Pull back, and then try to go again. No, we are there. Maybe if I go in the other direction.
Maybe we can discuss that while Carlos is busy.
No.
So I also tend to do
I'm trying to reach.
sphincteroplasty after doing EHL.
No.
If you do it
Can you give me
before, the problem is the saline doesn't
Just
hold
move
inside
everything.
the duct. So as soon as you're flushing it in, it comes back out.
Okay,
so
go.
I also tend to do it after doing the EHL.
That's a good point.
The other advantage is that you don't need a wire. You can do a freehand cannulation if you do a sphincteroplasty before. So
Remove.
you save time there.
Go again.
Yeah, I guess you can do freehand. If there's a previous sphincterotomy, you can do freehand either.
And for the
Even you have the resistance.
Story, but with
Let me
normal
see.
common bile duct and common hepatic.
No.
so and for the antibiotic for this patient,
Yeah.
you already cleared the duct.
Large stone, symptomatic, but you have normal common hepatic duct and
Let
common
me see.
CBD.
Yeah, inflated
Normal.
balloon.
Yeah.
And you have a large stone like this.
Sure. So I think again, I think nowadays cannulation is so much easier,
No.
especially with the new scopes, cholangioscopes you're seeing. I
Go
use lines at scope, and they're just so
No.
much easier, softer to go.
No, no, you are inside.
The spyglass version.
Let me see if I advance.
Easily cannulate, but otherwise you have a wire and
balloon.
balloon anyway. You need that. So just you use a long wire. If any problem, just go to the.
And Salim and the group, so obviously she got antibiotic, the patient got antibiotic during the procedure, and everybody is talking about risk of cholangitis. And how long typically you give them antibiotic after you're clearing the duct?
So we would normally give for 3 days. So I think that's the risk with the EHL. These are long procedures, so there is risk of bacteremia. So we would typically give 3 days of antibiotics post EHL.
And what is
very
your option of
important.
antibiotic? Like, is there any class you're using?
So if you go by evidence, I don't think there is much. But if patient is not penicillin allergic, we tend to go for comoxiclav. If they are, then generally Cipro.
Now
And I think that's a very important point because the risk of cholangitis is much, much higher when you are doing cholangioscopy. It can go up to 10 to 15%. Yeah. So antibiotic is really a must.
let's inject.
We in fact give a prophylactic as well. We give a prophylactic dose gentamicin and 3 days of antibiotics.
So, and what is your thought about, lots of patients, they have CBD stone, you stent.
We have very good hepatobiliary surgeon.
Okay, inflate until
They have
15.
Big common hepatic duct. He
Push.
did hepaticojejunostomy for 3 cases.
Now
no
we are
more
fantastic,
ERCPs, no more.
Okay, now I want that you inject.
I agree. I think
Yes.
sickle cells, patients, they are recurrence conform.
So inject
Are you injecting? Inject, please. So now I believe we finish here. I want to make some points regarding few things. So first, you need to evaluate that there is not more stones. I like it to see, you know, by fluoroscopy, that as I am looking now, first the fluoroscopy, please. So now, you see. So you can see now, everything is clear. I will review by cholangioscopy just to be sure that there is nothing there. Second, I want.
So now we will see, I say the war of the cholangioscopes, right? So we have different cholangioscopes now. We have different size, different approach. So we can have, you know, different kind of treatment that we can do it with these patients nowadays with the new cholangioscope, different working channel. And the most interesting is that we have less diameter, good quality of image with good working channel, that it will make change for sure the treatment of this patient in the biliary tract. As I mentioned, this technique in the future is the endosurgery of the biliopancreatic disease, right? Third, we have new kind of stents. So now we have from Q3 Medical. I use it a lot. We are almost ready to perform the first two experience with Archimedes. That is a plastic stent, biodegradable stent from Q3 Medical. You have different, you know, biodegradation. There are some faster biodegradation. It's almost in 15 days. The second one is medium degradation. That is almost a few weeks, like 6 weeks. And the other one, the fast, slow degradation, that is 3 months. Nowadays there are new one that is the metallic biodegradable stent. I believe this is, you have, both are plastic, but we have the metallic one. That is also a very good option. I use it a lot when I am doing treatment of biliodigestive anastomosis by antegrade way. So I put this metallic biodegradable stent. So we have a different kind of options today. I will see if we need to less plastic stent. If I will less, probably I will less this biodegradable stent. I believe it's not necessary in this case. In this case, because it's almost clean, and we will see if there is anything else that we can do for this patient. But I believe is almost done. I don't know if you have any other question before we close this room.
If you, Carlos, if you clear the duct, I guess you will not need any stent?
No, no stent.
Thank you.
Not necessary. I believe it's almost already clear.
Any more questions for Carlos from the floor?
Sorry, what was the question?
We may have a question.
So, if the bilirubin or alkaline phosphatase and GGT is sky high, and you cleared up the duct, do you still you don't put a stent and the alkaline phosphatase and GGT is high and the ducts are very dilated, and you're not sure that you remove the 2 centimeter, even if you do good occlusive cholangiogram? You don't put a stent in the left hepatic duct?
Carlos, can you hear us?
Yes.
So the question is, if you clear the duct, but the liver functions are abnormal, will, you know, if you're happy, will you still leave the patient without a stent, or will you go and put a stent in the left lobe of liver?
If I believe it's not necessary to less anything, I will be fine, you know, if everything is clear. That's why I will make a second look with the.
So biodegradable stent of 6 weeks, is it a good option here?
Well, I don't believe we need that stent in this patient,
Yeah.
to be honest.
I agree. I think if you clear the duct, then you don't.
Deflate?
Very occasionally, I've used a biodegradable stent only when ampulla is very edematous and you want just for a few weeks, you know, a stent, and just more for your reassurance, because these patients are at high risk of cholangitis bacteremia.
Yeah.
And you leave a biodegradable stent in, then you don't need to bring the patient back.
In this case, there is a protective
we have
factor. We
another
already made
question.
a balloon dilation, big balloon dilation. So if there is any rest, no risk, right? If you do a balloon dilation, I always try to make this balloon dilation at the end just to remove everything in an easier way, as you said, as you saw already. So I think it's not necessary to less a plastic stent. I believe everything was removed. I will do a second look, but off camera. Okay, inflate, yes? Yes.
So we have a question from the audience.
Yeah, when I deal with this kind of situation with an uncountable number of stone fragments, you know, at the end when I finish, before I put a stent, I usually advance my catheter to the most proximal part of common hepatic duct and wash the biliary tree with at least 100 ml of sterile saline. This will flush all the fragments down. Then I put a stent. I think this will prevent these gravels to become a nidus for future stones.
Well,
can you comment on that, Carlos?
I agree to use saline to clean up a little bit more if you need it. But even if you don't do it, if you remove the biggest stone and everything is okay, you know, there will be some sludge that will be there. But I don't believe we'll stop, you know, we'll be, you know, stuck it in this part because we already make a dilation. This is the advantage to make a balloon dilation. So everything will be, you know, remove it. I am still cleaning. I believe that in some kind of patients that when there is some risk of, you know, you less some stones or something like that, or if the patient is in cholangitis and this is not a very good, you know, cleaning, you need to use saline, clean like the surgeons, and then, you know, less a stent just because of prophylaxis. But, you know, I believe if you put a stent, this will be a risk factor to make more sludge or another, you know, stone. So I